Good afternoon, and welcome to the Quest Diagnostics sponsored webinar, Improve Your Bottom Line by Reducing Claim Denials. My name is Colby Dix, and I will serve as your moderator and host today. And our agenda for today is simple enough. We'll dive right into Mark's presentation shortly, and there'll be a brief Q&A directly following. Please also stay with us for a brief overview of Quantum Practice Solutions. I'd like to extend a warm welcome to our presenter today, Mark Anderson. Mark's bio is up on the screen now, and as you can see, we're very lucky to have someone with such expertise available to us. His 40-plus years of dedication to healthcare IT and consulting has earned him great renown in our industry. So welcome, Mark Anderson.
Well, thank you very much for inviting me to speak today, and I'm glad everybody was able to join us. As you can see from my bio, as they were saying, I've got a lot of experience in this area, especially working with physician offices. I've worked with physicians that are in small practices all the way up to large university settings with maybe over 2,500 doctors. But the majority of the people I've worked with have been smaller practices that really need help on making sure that their software product provides the optimum functionality they need to actually have a very financially successful organization. And part of that is denial management. A lot of people worry about getting the bills out and getting payments in, but denials management is one of the most critical portions of your day-to-day business, and most doctors don't know a lot about it. So we're going to talk about it today and how to make sure you're keeping your denials down to a minimum, which basically means more revenue coming into your practice.
Sounds great. I know it's definitely a perennial hot topic and one that we can't help but continue to address. Today's session will follow a question and answer style format in which I will be asking these questions of Mark. He will then provide the answers and the insight that we hope will provide quite useful to you. Today's topic, as he said, is denials, which, as we know, of course, is a major concern to the strong majority of active practices today. And before we go into the deep dive, Mark, do you mind giving us a bit of an overview of denial management and how it affects practices today?
Sure. There's really two things when you look at this, and part of this is, was the claim accepted by the insurance company? Now, once the claim gets into the insurance company, they bring it into what they call their adjudication system, and if things are not exactly right, they will deny the claim. So you got some of the claims coming in that just get rejected. These are claims that are accepted by the insurance plan, and they reject them for a series of reasons. And there are 350 different reasons that an individual insurance plan can deny your claim. And a lot of times it's because the patient's not eligible or timely filing, issues like that. But it's always important you have to track all of these because there's a limited time that you have to respond to any kind of denial. And in most of the products out there today, they don't really provide a denial management system. They will give you a listing of denials, which is not enough. We need to know what's going on, why they're being denied, by insurance plan, by denial reason. So that's why it's so important to have a lot more information than just that one claim denied. You may have 100 claims denying for the exact same reason. Don't work all 100. Find out what the problem is and solve that problem versus fixing each denial individually. So think about it, denials is a major problem for most practices out there, and most doctors don't even get key performance indicators telling them how many denials they had because the practice administrators in a lot of cases may not even know, or they don't want to tell you how many claims got denied. But depending on how your office works and how effective they are, your denial rate can be anywhere from 8% all the way up to 35%. That means you've done the work, you've delivered the services, and you're not going to get paid for the services because of something that was wrong in the actual claim, and we'll get into that in a little bit. But for the average physician practice out there, if you look at how much time it takes to look at the denial, fix the denial, resubmit the claim, on average it takes about $25 in cost to go through every single claim that is denied because you just can't resubmit. You have to go in and research it and actually fix it. And as I mentioned, depending on the insurance plan, you only have 30 to 90 days to provide an adequate response to that denial, or the insurance plan does not have to pay. Again, you delivered the services, you billed for it, but the insurance plan says we don't have to pay because one of these 350 denial reasons. And realistically, think about it. The insurance companies save money if they can deny the claim, so they're always looking for reasons to deny the claim. don't give them those reasons. Make sure your bill goes out clean and that you eliminate the denials going forward. Now, you start looking at the reasons for denials. As I mentioned earlier, eligibility denials are probably the number one requirement as far as volume out there. And that's basically this patient is not eligible for care delivered today by that insurance plan. A lot of times it's because we had the wrong insurance plan in there or the wrong, code that was put in, or that the patient, they dropped their insurance last month, or the insurance doesn't become eligible for the next week or so. And that's a simple way of solving that problem, which is doing eligibility checks up front. And we'll get into how the detail to do that. But there should be some kind of color coding on the scheduling desk that shows if somebody has gone through and their eligibility has been checked and verified. Again, if you have not done that, you may be providing services and doing all the work for billing, and you'll never get paid for the service. The whole question is, why aren't they checking eligibility beforehand? And you can't just check that when they made the appointment. They may have made the appointment 2 weeks ago. They were eligible then, but were they eligible when they showed up that morning? You need to know that. So these are very critical steps for all practices to make sure you reduce eligibility denials, again, which is the number one reason for denials is eligibility. There's a couple other tools you got to think about under this. Reminder tools. This tool targets all the patients when they're going to be coming back in, tracks the no-shows, looks at all the kind of information, maybe sends an email message out, a text message, or a phone message reminding the patient to come back in. And also, when it keys that, it can do another eligibility check. You want to make sure these systems have the capability of doing batch eligibility when you schedule the patient, and then, again, eligibility once we know the patient's coming in. A lot of times that's done the night before. Let's have it run through another eligibility check, and then on the schedule itself, it shows if they passed eligibility. And if they don't, you call the patient. Hey, I noticed, Mr. Jones, according to your insurance plan, you're no longer eligible. Did you change your insurance information? Do we have the right information? You want to capture that before the patient comes in. The practice may decide still to see the patient, but you want to know if that patient has that insurance or not, because there's no sense in billing the insurance company. They're just going to deny it. Another good example now is we have the ability to scan in the insurance cards and the driver's licenses, and we can pull the data right off of that. A lot of times claims get denied because we spelled the patient's name wrong or the address doesn't match with the insurance company. Simple things like that. Again, the insurance companies are looking for reasons for denying the claim that they had received. If you're not matching the right information from that insurance card, it may get rejected. Therefore, let's scan the cards in and have that data from the card going directly into your practice management system, and then your staff doesn't have to retype it. The other thing that's very important on denials is making sure you've got a really good front-end coder, sometimes known as a scrubber system, that goes out and looks at all of the edits that are required. They're called CCI edits, LMRP edits. These are just terms that people use, but basically making sure that the CPT code you're using matches the diagnostic code. Simple example I always use, you don't need to do a chest x-ray when somebody comes in with a sprained ankle. So you got to make sure all those codes match up. The insurance plans will deny a claim if the diagnostic code does not match the CPT codes. Let's make sure your software product checks all that for you. So when the claim goes out, you've already made sure that all of the edits are matching what that one healthcare plan requirements are. And Medicare requirements are different from Medicaid, different from the healthcare plans, commercial accounts. So you got to make sure your software product has all of those edits built in, so you got a clean claim going out today. Now, one thing I always like to talk about too is, well, what does this mean to me as a practice? Let's just decide your practice is collecting $100,000 per month, and you've got a denial rate of 18%. So 18% of all your claims are being denied. And let's just assume that 55% of all your denials are for the reasons that can't be appealed. For instance, patient's not eligible. Now, there's things you can do about that. A timely filing, no authorization code. Again, if you're doing some kind of elective procedure and you haven't had an authorization code, they're not going to pay it. But you may find out that you had the authorization code, but you just didn't put it into the practice management system. It's all on paper. But just assuming that you're forget about those, that you're still looking at how many got denied. Let's assume your practice is late on refiling denied claims. And again, 29% of all denials are handled late. If it's late, they don't have to pay your bill. For the average practice or physician doing $100,000 a month, like for your surgeon, that means you're losing $153,000 per year in services that cannot be billed, and also that charge cannot be billed to the patient. If the insurance plan rejects it because it's denied, you cannot bill the patient for it anyway. So it's important, if you're only doing $20,000 a month, it's still a lot of money that you're losing from your practice. At $20,000 a month in revenue, you're losing $50,000 a year because you cannot handle timely filing or refiling of denials. So it's important to really concentrate on denials, fixing the problem. Now, one thing you want to look at is we call denial management. Every software product out there today gives you the ability to track that you had a denial. Yes, you had 18 denials yesterday. But what you really want to do, we call it Enhanced RCM software, is tracking the reason for the denials by healthcare plan and by cost. How much will it charge and what's the expected reimbursement? You want to find out how to solve the problem of the denial. Eliminate the denial before it occurred. Too many of the products out there today, which we call the Common RCM software, just give you a listing of denial and you work each one of them individually. I'd rather have a system that tells me I've got 50 claims denied because for this one healthcare plan, the physician has not been credentialed through them yet. And I wanted to hold all those claims until they get credentialed. I put the credential number in, and then all 50 claims get submitted at the same time. What I don't want to have to do is pull up every single claim that got rejected, put in the credential code, resubmit it, pull up the next claim, put the credential code in again, resubmit it. There are the enhanced products out there can find the reason for it. They can look at trends. They can see that all of a sudden a code may have changed, and now you're seeing a lot more denials coming from Blue Cross or whoever. Find out what the problem is, fix the problem, and then eliminate the denials. That's what we got to be doing. Don't spend all that time correcting one denial at a time. Eliminate the denial from occurring in the future by having more information. And you start looking at trends over time. Just look at the denials. Over the time with products that are we call more the Common RCM products, denials are going up every single year. Now, that's because, again, the insurance plans have a reason to deny the claim. If they deny it, they don't have to pay it. And they're coming up with a lot of additional rules for denying the claims. What we have found with the products that are more enhanced RCM, they have less denials in the beginning, but denials are coming down because, again, they are finding the problem, fixing the problem, and then the number of denials goes down. So with an enhanced product, you're going to get a pretty good, sizable reduction in the number of denials you have nationwide. Now, again, every practice is a little bit different, but again, the upfront denials for eligibility checking, for making sure the CPT code matches the diagnostic code, for making sure all of your codes are correct, those are a lot of reasons for the denials. And we got to figure that out right up front and eliminate the denials to save you time and make you more money because you've already done the work. So if you want to look at the monthly loss for a practice, again, this was based on 85 practices that we were dealing with. From 2005 to 2014, we really didn't have enough of these we call advanced products. We start looking at the loss to a product, to a practice out there, and really starts coming down with these enhanced products. So anytime you're looking at your product, you want to make sure it has the enhancement capabilities for tracking all the denials, because that's a big gap. You're talking about $22,500 versus $14,000 per month. That's you're talking about $8,000 per month or that you can have coming in just because you're able to track the denials and eliminate the denials up front. It's worth it to spend a little bit more time. Because realistically, you're going to save your staff a lot of time. It takes 5 times longer to go out and fix individual denials than determine what the problem is up front, fixing it one time and eliminating the denials. Saves time for your staff and collects more money for you.
Thanks, Mark. That's actually a really pretty comprehensive overview, and seeing those trends, particularly the improvement being made via enhanced RCM software, that's really poignant, showing just the value of just such software and such services. Moving forward, Mark, do you mind explaining the difference between a denial and a rejection? Because oftentimes we lump them together, but really they're quite different. Could you go into that a little bit?
Yes. And one of the things that a lot of doctors don't know about is called the clean claim rate. This is how many claims are generated out of your practice that is submitted to the clearinghouse that submits it directly to the healthcare plan. You may be going direct to the healthcare plan, but most people go through a clearinghouse. How many of your claims that are generated each day can go to the clearinghouse, get brought into the insurance plan's adjudication system, and they accept it? That's called the clean claim rate. Basically, all it's doing is making sure that your format that you're sending in matches what the format requirement is in the healthcare plan. And nationwide, we were running about 90% back in 2010. Nationwide now, we're about 98% of all claims are sent in clean. That's just because the rules are very set up. It's called the X12 standard for getting the claims submitted. But almost all the healthcare plans are using the exact same rules now. So the software vendors have been very good at updating their software to make sure that your format and all the requirements match exactly what the healthcare plan requires. These are not rejections, they're not denials, but this is where the healthcare plan says, yes, your bill does meet our format, we're not going to reject it from that point. And then they still may deny it later on, but if the claim doesn't get to the insurance plan in a clean format, nothing happens with it. So it's important to make sure that all the claims do not get rejected. And again, I'd be asking your insurance or your current software vendor, what is their average clean claim rate? And it should be above 95%. Now, again, some of the reasons for that, claims that do not meet the specific data requirements or the basic format will end up being rejected. Again, if they are rejected, what that means is the payer says, we never received it. It doesn't even exist. It came to their product. There's a wall that comes up and says, boop, never got it. And therefore, you can't call them up and ask them about it. You can't call them up. Like if you wait 60 days to call them, they're going to say, we never got it because it was rejected. And that's the typical response is, we never got it. So a lot of practice will resubmit it again, but it's going to get rejected again. You got to work the rejections because the healthcare plan says it never showed up in our system. You did not go through it all. And again, if it gets rejected, the patient cannot be held liable for that service. So if you send a claim in that gets rejected, you cannot turn around 3 months later and bill the patient for that because you're basically not following their requirements for submitting a claim. Therefore, you cannot bill the patient for it. So it's important to make sure you work all those rejections. But again, your rejection rate should be relatively small. I've got a couple of vendors out there that I've heard about that are running only a 70% clean claim rate. That means 30% of all the claims are being rejected, never received by the healthcare plan, which means your staff have to go back and look at all those rejections and work all of those. We want to make this thing seamless. You do a service, you send a bill out, it should go up and come back. And realistically, all payments should come back within 14 to 21 days. Nothing should go past that. And if you're running a days and accounts receivable over 21, there's a problem out there. And by having an advanced RCM product, you can solve a lot of those problems and reduce your days and accounts receivable, which basically improves reimbursement for your organization. As we already mentioned, denied claims, that was when the claim was received by the adjudication system of the payer. They reject it for one of those 350 reasons, and you cannot resubmit that claim unless you go back in and fix the problem. A lot of practice, if they get a denial, they'll just resubmit it. It's not going to do any good. Once it's been denied, it's denied. And you'll send it back in, they'll automatically reject it again because it's already been denied. You really have to work that claim. As I mentioned before, $25 for every rejection, counting all the staff time. Makes sense to work it in the beginning, solve the problem so you don't have those denials going forward. Now, we start looking again at denials versus rejections. Again, the number of rejections have really gone down from 2010 through 2018. As I mentioned, we're looking at almost 19% of all claims got rejected in 2010, and now we're down to 3 to 4%. Some of the advanced software products are down to 2% rejection rate, but the number of denials are still going up. The software product eliminates rejections, but it's up to the staff and advanced RCM functionality to lower the denial rate. So luckily, the software products have helped on rejections, but the denials are still a problem, and it's a growing problem for most practices.
That's a really telling graphic as well. I think obviously a lot of that is attributed to more small practices using more enhanced medical billing services, and of course even some of the practice management services that at least are supporting some clean claims, which is a good trend to be on. At least we're moving forward. Moving on, what are the most common reasons for denials, Mark?
Well, we already talked about the first one. Patient is not eligible. That's by far the biggest one. And again, that can be resolved. Probably 95% of all those claims can be eliminated if you're doing eligibility checking up front before the patient is seen. And we like the idea of once they schedule, you hit a button and it does batch eligibility checking. But then you also need to do eligibility checking maybe 2 days before the patient comes in. You don't want to wait for them to show up in the office to find out they're not eligible. Or even worse, you send a bill out and you find out they're not eligible because you can't collect from them. That's the number one reason. You get a number of other denials of duplicate claim. I sent the claim in. It either got rejected up front or got denied. So all the staff does is resubmit the claim again because there was no payment done. It doesn't make any sense to have a duplicate claim that hasn't been paid because of either rejection or denial rate. So get those things down because you still got to work them. The next one is, again, having the coder scrubber system make sure that your CPT codes match the ICD-10 codes. I'm amazed on how many times the actual CPT code where a procedure you're doing will not match what the diagnostic is. Again, doing a venipuncture, taking blood for somebody who has a sprained ankle, they're probably not going to pay that. They will reject the whole claim because one extra procedure, something that you did in the office, doesn't match what the diagnostic code is. They'll eliminate the whole claim. It may be a $5 charge for something, but they will not pay any of it because of that. Timely filing is a big one. You only have so many days to file the claim. And I still have practices that, sometimes 15, 20 days after services, they haven't filed the claim yet because they're waiting on a piece of information. Or that the claim got rejected or denied and you followed up with it, but it's not within that 21 or 30 days. Remember, every healthcare plan has different timely filing requirements. That needs to be built into your system that alerts the billers or accounts receivable follow-up people to say, these are the accounts I need to work first because these are the ones that are getting close to timely filing. Timely filing deals with when that claim is accepted by the healthcare plan. If it gets rejected, remember, the claim never existed. So timely filing starts with when you did the service and when they receive the actual claim or response to the denial. You're limited on how much time you can do there. The other one is out-of-network services. A lot of patients are out of, they have a plan that requires you to go to a certain doctor. They're now seeing you because you're out of network. Again, the eligibility system will tell you that part. Outdated codes. Many practices don't know that the codes change every quarter. You need to get the updates hopefully from the insurance, from your software vendor, updating all the codes. Medicare, Medicaid, the commercial accounts out there, there's not a lot of change, but every quarter there's an update to the code system, what they pay, how they pay. If you don't get that update, those claims could get denied because you don't have the updated codes. But that's got to come from your vendor because it's impossible for a practice to figure out what codes have changed. By Blue Cross, Aetna, Cigna, United, Medicare, Medicaid, you can't track all that. Your software vendor should be giving you all that information. And, of course, a lot of the denials are because insufficient information. There's not enough information on the claim that goes out. And, again, a lot of times that might be it's a workman's comp claim or an auto injury claim. But all you report is person hurt their back. And the first thing that the insurance plan is going to do is it's kind of like called pending claim. We're pending for more information. That also kind of falls in the denial area. If you don't respond to the pending claim waiting for information, after a period of time, the insurance plan does not have to pay it. So, again, having a system that tracks all of this for you and tells you how many claims you have, what the dollar amount is by insurance plan by month, so you can analyze all that. That's what you have to have in the advanced RCM product.
Mark, when we're talking about denial management as a function, what do we really mean there? Like, what can we expect from a basic practice management or an RCM service perspective?
Well, so once a claim gets denied, there's two ways. The biller either posts the information into your billing system, the RCM product, or more likely now it's all fully integrated in. So all the payments come in electronically and all the denials come in electronically. And so it automatically might post in the system. But somehow the denial has to get into the system, and either that same person may work it or it goes to a secondary person to follow up on denials. Many times I'll have a billing person, depending on the size of the practice, who will just basically make sure all the payments come in, make sure it's correct, maybe send the bill to the secondary or assign the rest of the bill to the patient. And certain people just work denial claims. But again, it's important to work those denial claims, have people really understand it. It's not something that's very simple. You have to really go and research why it got denied and to figure out what we can change on the claim so it can get paid. So you review the information, you figure out which claims you can resubmit, and then you really work those claims. Either you have to write it off as a contractual allowance, or that maybe you can resubmit it in. But again, I need to know that if it got denied, what the denial reason was. And you get a report showing the denial reason, but most people don't track it that way. They just write it off. Okay, we can't bill for it. I need to know why it got written off, what denial reason. Because your common RCM product just says you wrote off $50,000. But why? Was it because the patient couldn't pay their bill, or because of contractual allowances, or because it got denied, or it was timely filing? You need to track why things got not paid what you're expecting. And there's all these different reasons for it. And again, once you figure that out and tracking all of that, you have to look at what did you do to fix the claim? What was the problem with it? Learn from that to eliminate denials even coming in. Stop fixing a denial problem, find out what caused the problem, and fix the reason why the claims got denied. Again, nationwide, 29% of denial claims are not processed in a timely manner, ended up getting written off. And you need to keep track of how much money are you writing off because of timely filing. Timely filing is submitting the claim, and timely filing and responding to the denial. It is amazing how much money that is. You could be looking at $30,000 to $40,000 per physician per year because the staff did not have time to follow up on a denial. That's important to know. How much money are you writing off because the staff didn't follow up in a timely manner? That's an important indicator every doctor should be asking about today.
Excellent. I mean, it's great, and it really illustrates the need to change the way that many of us go about handling claims, and indeed just the way that we perceive denials in general. But now, if you don't mind, if you could contrast those common procedures with the more enhanced feature set that's available with a premium service like Quantum RCM, and what are the benefits to those?
Well, the advanced RCM products, and we only find them in about 15% of the software products that are out there today, so this is not something that's common out there. But again, the first thing it does, it gives your practice administrator a nice report that tells you how many denials by insurance plan, by denial reason, by month. You can look at trends. Think of it as a big spreadsheet. But the important thing is when I see a number, I see Blue Cross had 50 denials, I can click on that denial reason or dollar amount, and it drills down in. I can see the detail behind it. What you're looking for is trends. Why is something getting denied? Oh, a code changed last month, and we didn't update that code. Now I know what the reason is. I need to go back into the practice management system, update that code in my master file to eliminate those denials going forward. Ideally, somebody should be working the denial reasons on a weekly basis. You've got the staff fixing the denial, but somebody really on the management side or the analytics side, depending on the size of the practice, is looking at all this to eliminate the denials. For every denial you eliminate, you're eliminating a lot of work on the back end that somebody has to work on. So looking at all that, monthly is what you have to do. I'd like to be able to get down to, I'm looking at every week, have somebody look at it. And you're looking at what that trend is. What has changed? What's going on? All of a sudden, eligibility rejections are going up. Why? What are we not doing? So figuring that part out. The goal is to identify and eliminate the reason for the denials, not just fix it. And from the studies we've done with advanced RCM, we can reduce denials by over 40% by just building in a workflow process around advanced RCM processes. 40% reduction in denials means you got potentially, if every claim on average is the same dollar, that's a 40% increase in income coming in, and basically a 40% reduction in staff time working those denials. So it's a big number out there. Remember, for every denial, you already provided the service, and you're not going to get paid a dime for it. I need to eliminate these denials first. So again, with a lot of these systems too, if a claim is denied, the denial is automatically routed to the appropriate follow-up person. No one has to go look for it. It should automatically come into somebody who looks at it. If it's an eligibility question that got denied, it should go to whoever's over the registration area or the scheduling area to make sure we're checking eligibility correctly. So, and these systems automatically track how many denials by denial reason by insurance plan. And as I mentioned too, if the claim must be written off because of whatever reason, you need to track that denial reason. Don't call it contractual allowance because that's not what it is. It's a denial. You're not going to get paid because somebody did something wrong in the practice up front that could have been corrected. Your denial rate should be under 1%. And the goal is to get it down to 0 denials. If your product is working effectively with your EHR, there should be no denials because the system should be checking for all of that. And nationwide, you're averaging 18%. We got to fix that problem. But again, it puts it into a work list. It sorts it by dollar amount. Work the high denial dollar amount first. If it's a $5 charge for something, put that last on the list. If you're talking about a surgery that got denied and it's a $1,200 charge, work those claims first. But also look at it by healthcare plan. How much time do you have to work on the denial and resubmit it? Because if it's not handled in a timely manner, you will not get paid for it.
Let's take a little step back then, zoom out a notch, and talk about the steps that we can take as physicians and office managers to help reduce the cost of denials to our business. I know you've touched on some of these points already, but we'll go ahead and reiterate the point and go a little deeper dive into that. I know you've got some solid suggestions here to get us on the right track regardless of the system that they currently have in place.
Yeah, as I mentioned, the number one reason for denials is eligibility. So that's your very first one to look at. Automatically do pre-eligibility checking at the time of the appointment. Most of the advanced products today, that once you set up the appointment, at the end of the appointment, or when you set it up, you schedule it, the system will automatically go out and check eligibility. And typically within 5 to 10 seconds, you're going to get a response back. You can still have the patient on the phone, and you're talking about, okay, I've got you coming in on a Monday at 2 o'clock. Oops, I just got a message that says you're not eligible. We got to collect better information about the insurance, or do you really have insurance? Get it right up front. But then have it do a batch eligibility. I like doing it 2 days before the appointment. Have it go out there again, check the eligibility, make sure they're still eligible. You get a report back that says, of your 30 patients that are coming in 2 days, 3 of them are not eligible. That gives you time to call the patient up, check on the information. Maybe you find out you got the wrong information in, or you want to now set up a payment plan for that patient. You're no longer eligible for the insurance, so when you come in, we think your charge is going to be $100. How are you going to pay for this? Get an arrangement with the patient on how they're going to pay if they don't have the insurance. Don't wait for the patient to show up in the office to say, oh, you're not eligible. And the person says, oh, I don't have my credit card or my checkbook with me. Just bill me later. Good luck collecting for the patient, bill me later approach. You want to collect it right up front. Again, think about it. The cost is the same if you send 1 eligibility check or 1,000 eligibility checks. Most of the vendors out there charge a flat fee for eligibility checking, and it's around $20 to $25 per month. So check it multiple times. Don't wait. These few steps right there can eliminate 38% of all the denials, which again means you're going to get paid, and the staff don't have to spend all the time tracking down the reason for the denial, figuring it out, calling the patient, reworking it, resubmitting it. Eliminate the work by eliminating the denial up front. Now, let's just say you got a denial, and it's not for eligibility. Now, you really want to look at what is the reason for the denial, and they give you a code. Sometimes that code could mean I rejected the whole claim or maybe just one line item. We see that a lot of times. They'll reject one line item and the staff does nothing with it. Well, that one line item may be $50 to $100. Or if it rejects the whole claim, it's even worse. But you got to find out what happened, what was it, and create a strategy for eliminating high-cost denials. Too many practices, again, just work the denial. They don't come up with a strategy for eliminating denials. You sit down with the staff. You figure out what the problems are. And what I like to have is every single denial gets touched within 24 hours. And no matter what, you set up a plan that every denial is followed up on within 7 days. And you can create workload lists that show you've had so many denials, and within 24 hours, somebody's touched it. If it hasn't touched it, it goes to a supervisor that says, we've missed some claims. And that you also want to track how many denials came in and how many denials did not get responded to and resubmitted within 7 days. Because now you're going to forget about it. You're working on something else. And now it's timely refiling of a denial. Create work lists that automatically tell someone what they need to do, what they need to work, and then track which denials have not been worked on. Again, it's all about monitoring your success and eliminating the denials. Get to a plan that only 1% of your claims get denied. That should be your strategy and your goal. And you may be running 18% today, but keep working with your practice management vendor and some of the services they have to start getting to the point of eliminating those denials in the future with a goal of getting it less than 1%. Rarely do I find any practices less than 1%. For the practices I've worked with, we've got it down to under 2%. So it's the capabilities there if you work the claims and understand what the problems are.
All right, then. That's really quite a bit to think about and some really important points to consider that we can all put into practice today. I'll also just remind everyone that the slide deck and recording will be included in the webinar follow-up so that you can reference these tips again in the future. But in a more immediate sense, Mark, let's talk about a few next steps for our audience to take away from this session. Where do we go from here?
As it's kind of more of a recap right now. Understanding your denials, getting a key performance indicator that tells you how many denials you have, how many rejected claims you have, and what the dollar amount is by reason. That's just something that the physician gets every single month that has that information. And obviously make sure that you've got a denial management program that gives you that kind of information. Without the information, you don't know what's going on. And then start looking at a strategy for eliminating the denials for eligibility or for prior authorizations not there. Getting a clean claim rate over 98.5%. If you don't know what your clean claim rate is, that's a problem right there. You got to know what that is. The next one, it says CCO. It should be CCI. Your little typo there. CCI and LMRP edits. These are the ones that codes get rejected because it doesn't match all the coding requirements. So look at all of that kind of stuff. And again, that's usually covered by advanced claim scrubbers that's out there tied to your EHR product. Because it should be looking for those automatically. And create a goal of getting your denials less than 1%. As I keep saying and I keep repeating, don't just fix the denial, fix why the denial occurred. This should be your goal going forward in the next year. And making sure, if you're a physician or a practice administrator, make sure you have these numbers on your fingertips on a monthly basis to show you've got a strategy and you're improving on that strategy, because it basically means better productivity for your staff and more money coming into the practice.
Mark, let me just thank you so much once again for this presentation. There was a wealth of information covered here, and it's truly invaluable, things that we can all put into practice immediately. But we will transition now into the question and answer portion. We have Mark with us, of course, as well as representatives from Quantum RCM to answer any product-specific questions that you might have for us. Mark, we do have a couple of questions in the system here already. If you don't mind, let me begin with this one. It seems like a lot of our denials are the result of the incorrect information we receive from the payer when we verify benefits. Are there any specific ways to help prevent this? Now, this came in earlier in the session. I know you addressed it, but if you don't mind, just put one more pin in that one.
Well, you got to remember, whatever the payer is giving you is the correct information that they have. So the payer may have the wrong information, but that's all they're going to pay off of. So assume what you're getting from the payer is correct. And that's why the eligibility checking is so important, because it's going to bring back to you exactly what the healthcare plan has in their database. It doesn't matter if you've got the correct data. It only matters what they've got, because they're matching up whatever you send to them with what they have in their database. If it doesn't match, they're going to reject the claim, and it'll probably be more of a denial than a rejection. Because, again, remember, rejection comes to them, never gets into their system to even check for those things. But you want to make sure you've got advanced eligibility checking. It should tell you exactly what they're eligible for. It should tell you exactly what the copay amount is. I've got a couple of clearinghouses I found with certain vendors that are out there where you don't even get what the actual copay is for the primary care and the specialist. So how do you know what to collect from the patient? And with patients having these high deductible amounts, many times the patient's seeing doctors for 3 or 4 months before they even come close to meeting their deductible. Personally, my deductible is $7,500 a year right now. I never hit my deductible amount. So no matter what, the practice has to collect the money from me. These are all tools that help you figure out what you can collect, because the claim has to go in clean. It has to be fully adjudicated without a denial, and then you have that contractual write-off. Then you can bill me. But if it gets denied or gets rejected, you can't bill me. So make sure all that's covered up front.
Thanks, Mark. Another question that came in, this one, we have a lot of frustration in our office with the insurance companies, and there's sometimes excessive requests for patient info and medical records that seem wildly inconsistent from one company to another. Is there a standard in place here, and is this something that an enhanced RCM can better assist with?
Yes, typically those are classified as pending claims. I'm pending the claim for more information. And I see that a lot because think about auto injury, personal injury, workman's comp claims. None of those are paid for by the insurance plan. So if they can come up and reject the claim by saying it might be related to an auto injury, somebody fell. Oh, did they fall at home? Did they fall at work? Their goal up front is to reject it. Or they want to see a lab result. What you want to do is track all your pending claims and the reason for pending. For instance, we know if there's something about a fall, you automatically need to put something in there to prove that it was a health-related claim. It was not workman's comp. It was not auto injury. It was not personal injury. If you can track all that, you can automatically submit the claim with the right information right up front. Don't wait for them to reject the claim by pending it, and then you have 2 weeks to follow up on it. Know what the requirements are going to be and automatically submit that. There's ways of submitting the claim electronically with an attached document. If they're going to ask for it every time, send it to them up front every time. Don't wait for them to pen the claim waiting for more information. But that's where the advanced RCM products can do that. The common products out there, you can't attach a document with your claim. The advanced products can do that.
Another question here. If we see a systematic incorrect denial reason from the payer, how can the RCM software support this? Example, as an independent lab, we see rejections for incorrect place of service for laboratory code.
We see that a lot with labs out there. I've seen the certain practices, too, depending where you're doing the work. You've got to have the right place of service code. Again, the insurance company has requirements. You have to make sure that your RCM product is matching those requirements. So again, tracking those reasons for denials, getting that information, and then going back in and updating your RCM product, mostly the advanced products that are out there, the enhanced ones, to automatically check for that. If they got the wrong place of service code, that claim should never even be submitted. Your scrubber should be catching that up front, putting it into a work queue for the people to work before that claim even gets sent to the insurance plan. Correct it up front before you submit it, because once you submit it, you got all kind of additional work that has to go on. But your internal revenue cycle scrubber and your EHR scrubber should be catching all of those up front. In the case of a lab, you don't have the EHR, but you have a lab information system, you've got your billing system, but it should be looking for those codes. If the code doesn't match, that claim should never be submitted. And just those codes should then print out on a work list for somebody to go back in and correct.
Very good. I have another here that we could probably triage a bit, both with Mark and perhaps Cynthia or another member of our Quantum RCM team. How long does it take to put a billing service partner into place to get them up and running? And how long should they stay with an existing service if they intend to change? So I've kind of a split question there, but most of it's basically focused on how long does it take to get up and running, speed to market on with a new medical billing service partner.
The challenge with going on a new revenue cycle product is, I can install a revenue cycle product tomorrow for you, but I got to train all the staff. What do you do with all the data on the old system is the big thing. And the typical response is keep all the old revenue cycle on the old system, start new on the new system, because it's very hard to convert over all of that data. Now, I like the idea of converting over, if there's a patient balance, converting it over to the new system, because I don't want to get a bill from the old system to a bill from the new system. But you can only submit the claim, because it's all tied to whoever your billing software product is, through the clearinghouses. Work the claims off the old system, but get on a new system. And typically you can get that done under 30 days normally. I'm not sure how fast you guys can do it, but you can switch over. And again, it could mean an improvement of 10 to 15% of your reimbursement by switching to an enhanced system over the old practice management system you've been using for years.
Thank you, Mark. Hi, this is Cynthia. So I just wanted to add, I absolutely agree with Mark. Switching over to an RCM system, the one thing that may be delayed is enrollments with the clearinghouse. So within 30 days, you should be able to switch over. However, some of the carriers do take a little longer, and but that does not stop the majority of the claims going over. So I just wanted to point out that may be a small delay on the enrollments.
And one of the questions is, if I stay with the same clearinghouse, is it still delayed? Because sometimes you could be, because a lot of times the RCM vendor doesn't care which clearinghouse you use. Is it better to stay on the same clearinghouse or to get a different clearinghouse when you switch your RCM product?
The clearinghouse may depend on the vendor, if the vendor is connected to that clearinghouse. So if you're already enrolled, fantastic. You don't have to do that again if you stay with the same clearinghouse. If the enhanced RCM, software solution has a different clearinghouse, then you would have to do the enrollment.
Right.
Excellent. Well, that's it for questions in the queue. I will go ahead and put one more to Cynthia myself and just ask if there's anything that you think we missed in this session or anything that you wanted to highlight before we close it out for the day.
The one thing I do want to highlight, and I absolutely love that Mark really touched on this multiple times, is not only do you just want to fix the denial, you really want to find and identify the root cause, because that is, as what he shared with you, that is what I see, is it's a continuous, never-ending cycle of fixing the same thing. You want to analyze, identify, and fix the root cause.
Outstanding. Mark, let me thank you once again for your time and your expertise today. And of course, Cynthia and our staff from Quantum RCM who have joined and were available as well. We do appreciate your time very much. Mark's contact info is on the screen now, and the resources, of course, will be included as part of the follow-up documents that you receive after the presentation. So if further questions do arise, don't hesitate to reach out. And as well, if you have more questions about quantum practice solutions, please feel free to call or email using the contact information on your screen now. Once again, we thank all of you for your attendance today. Special thanks to Mark and the Quantum RCM resource team once again. And please stay tuned just after this session for a brief but informative video covering the breadth of quantum practice solutions available for your practice. Well, thank you so much. That will conclude the live session today.